Our 11th lesson deals with the topic of spirituality and spiritual care. Understanding the essence of spirituality and spiritual care is much needed to ensure the spiritual health and well-being of those living with neurological illnesses. Palliative care is about the mind, body, and spirit. This session discusses spirituality and spiritual care as an integral component of palliative care. We will look at the definitions, models to provide spiritual care to Parkinson patients and their caregivers, and point out the importance of spiritual legacy work. Let us begin with some general facts about spirituality and spiritual care. The complex challenges that arise from the nature of the disease trajectory radically affect the patient's sense of self, challenge personal beliefs and relationships, and diminishes the feeling of belonging. As you learned in Lesson 2, the WHO definition of palliative care suggests that palliative care addresses patient needs in the physical, social, psychological, and spiritual domains. Palliative care for patients with chronic and progressive neurological disease is underdeveloped. Within neurodegenerative diseases, there is limited evidence of the effectiveness of careful assessment and management of all aspects of care, physical, emotional, social, and spiritual, as part of a palliative care approach. It is important to remember that despite the growing body of evidence about associations between spirituality and health outcomes, such associations have to be interpreted in suitable causal networks, taking into account the historical developments and socio-cultural specificities. That means that care models or assessment tools that function in one country or even in one healthcare organization do not necessarily serve the same purpose elsewhere. Demographic transition has resulted in a significant increase in the elderly population, bringing to the fore degenerative neurological diseases such as stroke, Alzheimer's disease, and Parkinson's disease. According to the WHO, the extension of life expectancy and aging of populations globally predicts a rise in the prevalence of neurological and other chronic disorders and the disability. Patients with chronic neurodegenerative disorders suffer from the burden of disease progression without the hope for a cure. Therefore, symptom management and palliative care approach should be included, from the beginning of the illness until death and beyond. Lancet's call for action specifies, as the world population ages, comorbidity also increases. A shift from a health system centered in medical specialties to person-centered care is required. The global aspiration is that patients with chronic life-limiting conditions should be introduced to generalist palliative care. Referral for specialist palliative care support should be made at any time when physical, social, psychological, or spiritual unmet needs are unsatisfactorily resolved by the primary caring team, even if the treatments are ongoing. Before we head on, you might want to ask yourself, what do terms spiritual, existential, and religious mean to you? Are you spiritual? Do you consider yourself religious? What or who matters to you most in your life? What or who gives meaning to your life? Problems continue to arise in many places because spirituality is understood to belong only to religious traditions. In some languages, translation of the word spirituality is synonymous with religion. In regions with a Roman Catholic tradition, spirituality is recognized as the core of religion. This confusion can lead to some patients rejecting spiritual care on grounds of not being religious. As a result, patient concerns around non-religious meaning-seeking and meaning-making are neglected. In countries where religious talk is forbidden in the workplace, problems arise, if this confusion exists. This raises the question of whether an alternative term, such as existential care, should be used. It is recommended that each country's representatives decide the appropriate term be used in their language to maximize acceptance of spiritual care. However, this session will continue to use the term spirituality to remain consistent with the WHO definition of palliative care. Plus, we support the idea that spirituality is universal, deeply personal and individual, It goes beyond formal notions of ritual or religious practice to encompass the unique capacity of each individual. Spirituality is at the core and essence of who we are, that spark that permeates the entire fabric of the person and demands that we are all worthy of dignity and respect. It transcends intellectual capability, elevating the status of all of humanity. Now, let us take a look at available definitions. In May 1984, the World Health Assembly Resolution 37.13 made the spiritual dimension part and parcel of WHO member states' strategies for health. According to the WHO, the spiritual dimension is understood to imply a phenomenon that is not material but belongs to the realm of ideas, beliefs, values and ethics that have arisen in the minds and conscience of human beings, particularly ennobling ideas. The spiritual dimension plays a great role in motivating people's achievement in all aspects of life. Hence, the spiritual dimension is an integral meaning-giving aspect of human existence, and thus, spiritual needs are universally experienced by healthcare professionals, patients, and caregivers, particularly during critical and transformative life events. Accordingly, the spiritual field is multidimensional, containing existential challenges, such as questions concerning identity, meaning, suffering and death, guilt and shame, reconciliation and forgiveness, freedom and responsibility, hope and despair, love and joy. Secondly, value-based considerations and attitudes, what is most important for each person, such as relations to oneself, family, friends, work, things, nature, art and culture, ethics and morals, and life itself. And finally, religious considerations and foundations, for example, faith, beliefs, and practices, the relationship with God or the ultimate. While religious spirituality, in which religion provides identity, morals, and faith in a higher power, may be distinguished from secular spirituality, which emphasizes unity, integrity, holism, and individuality, the working definition of the EAP Spiritual Care Reference Group comprises both. Spiritual care is not a synonym for healthcare chaplaincy. It is not a burdensome addition to normal care. Spiritual care is openness towards the spiritual dimension and acknowledges patients' and caregivers' needs, options, resources, civil rights, and possible spiritual or religious limits. Spiritual care is tolerance towards patients and caregivers' wish not to discuss spiritual needs and concerns with healthcare providers. Spiritual care in palliative care pays attention to spirituality via presence, empowerment, and bringing peace. Essentially, addressing spirituality and providing spiritual care is a shared responsibility of physicians, nurses, psychotherapists, chaplains, and other health professionals. Still, we can differentiate between generalists and healthcare spiritual care workers. Generalist spiritual care involves recognizing the importance of the spiritual dimension of care for patients and involves needs assessment and provision of support. Healthcare spiritual care worker is a staff member who has specialized in spiritual care within healthcare institutions, dedicated to the spiritual care of patients, regardless of their religious background. May also be called chaplain, pastoral care worker, board-certified chaplain, healthcare spiritual care worker, priest or another term, including humanistic counselors or existential philosophers specialized in spiritual care. In some countries, rather than using a spiritual care worker trained for healthcare, spiritual care is the exclusive domain of a member of a religious community, for example, a priest, whose willingness to provide spiritual care is not guaranteed. Some priests prefer to limit their patient interactions to religious rituals, and some are extremely under-resourced and could not meet the needs of all patients even if they wanted to. Sometimes spiritual care is the domain of volunteers or trained staff members rather than full-time spiritual care staff, which can also lead to gaps and lack of standardization in the provision of spiritual care. According to Gammandi and colleagues, the spiritual care competencies in palliative care are as follows: to demonstrate personal reflective practice, To integrate the patient's and family's spiritual needs in the care plan. To provide opportunities for patients and families to express their spirituality. To be conscious of the boundaries that may need to be respected in terms of cultural taboos, values, and choices. These competencies are extended and clarified in an EAPC white paper on multidisciplinary education for spiritual care in palliative care, that was published in 2020. This article is provided as additional reading material within this lesson. Spirituality in itself is very subjective and it changes depending on the individual's perception of self, personal aspirations and unmet needs, and other possible life stressors, such as self-perceived loneliness or financial concerns. The subjectivity of all these notions and the endless field of possible determinants that may affect patients and their caregivers are the main reason why the recent EAPC white paper on spiritual care education in palliative care differs from earlier papers in this field. This encourages the initial conversation about spirituality, which allows the patient to express his or her beliefs and values. Such conversations establish a connection between the patient, caregiver, and the healthcare provider. A conversation about spirituality is to be seen as a crucial first step in establishing a therapeutic relationship, which prepares the ground for screenings and clinical assessments that take place in parallel but cannot replace the conversation. As spirituality is not necessarily a matter of everyday conversations in the clinical setting, such initial conversations prepare patients to share aspects that otherwise might be considered as very private. The patient's choice to disregard this aspect of care is to be respected. Keeping this in mind, we will look at integrated spiritual care for patients and caregivers with neurodegenerative conditions. A belief and value-based care model for people with life-limiting conditions have been proposed by Arthur Kleinman already decades ago. Kleinman argued that finding a proper explanation for falling ill may be seen as the first step towards coping with the disease. What Kleinman calls explanatory models are patients' and caregivers' responses to particular situations and are therefore idiosyncratic, changeable and heavily influenced by both personality and cultural factors. Therefore, the idea of being incurably ill and dying must be continuously negotiated. This continuous negotiation must take place between healthcare providers, patients, and caregivers. Here you see an integrated spiritual care model for patients with neurodegenerative disease and their caregivers. This model is based on an extensive literature search looking into the evidence regarding the spiritual care needs of this population. The comprehensive care model consists of four main pillars. Firstly, the initial talk, what to expect. The new science of prognostication, the estimating and communication what to expect, is in its infancy and the evidence base to support best practices is lacking. Across the world, cultural practices, superstitious beliefs, ignorance, and social stigma may impede the delivery of neurologic care. Honest communication about uncertainties over prognosis, and the impact of interventions and ascertainment of individuals' values and beliefs make for better care. Hence, formulating a prediction and communicating what to expect with patients, families and surrogates in the context of common neurodegenerative disease is of major importance. Secondly, monitoring the changes and negotiating. The idea of being incurably ill and dying must be continuously negotiated. This continuous negotiation must take place between healthcare providers, patients, and caregivers. It has been estimated that the spiritual needs change during the progression of the disease, also due to brain degeneration. In this regard, not only clinical work but research in spiritual care for patients with neurological diseases has to be capable of capturing the stages of bodily failure, changes in self, feeling of not belonging or being a burden, this all to prevent distress, suffering, and pain as well as loss of faith, particularly in healthcare systems. Thirdly, preventing isolation and demonstrating belonging. To prevent isolation and demonstrate belonging, inquire about patients' and caregivers' social connections and support networks. If patients and caregivers fail to identify such support, share information about patient associations, support groups, consider providing healthcare provider or volunteer home visits or maintaining regular contact via telehealth services. Finally, legacy work at the end of life. Legacy work, where patient's biography is told, written down, edited, and exquisitely bound as a keepsake, is gaining ground in palliative care. Nearing the end of life, spiritual legacy work and dignity therapy may be provided by healthcare spiritual care workers. However, each healthcare worker is in the position to promote spiritual well-being and dignity in dying by encouraging patients to articulate their preferences and learning to listen to what they say. Spirituality is a complex phenomenon, and that multiple areas of the brain are responsible for the many aspects of spiritual experiences. Over the past decade, scientists have tried to locate the spirituality and religious beliefs in brain areas. Quite many publications exist in which religious beliefs are shown to be connected to certain brain regions. Especially gray matter volume has been found to correlate with spirituality. Furthermore, the complex network of subcortical and frontoparietal areas, as well as temporal areas, seems to play an important role in spirituality. But also other brain regions are involved in the context of religious feelings, like the limbic system, the thalamus, the insular cortex, the anterior and posterior cingulate cortices. According to these data, it is unsurprising that neurodegenerative disorders and other causes of brain damage can modulate religious and spiritual experiences. Recently, it has been demonstrated that lesions of specific brain areas can modulate spiritual experiences. That frontotemporal dementia or temporal lobe epilepsy changes religious behavior is well known. Knowing that changes in the brain imply our beliefs and values, it is important to consider spirituality and religious beliefs whilst caring for people with neurological diseases. In many regions across the world, the belief in supernatural factors as a cause for neurological and psychiatric illness, including the evil eye, divine testing, punishment, and sorcery, is still very much prevailing. In many parts of the world, the patient with epilepsy was, and unfortunately still is, considered to be unclean, touched by evil forces, and contagious. At others, he or she was considered divine magic, and able to utter prophetic oaths. Even without demonizing the illness, the diagnosis of neurodegenerative disease is devastating for patients and their families. It challenges the patients emotionally, compromises identity, challenges independence, forces patients and their caregivers into social isolation, and threatens the ability to find meaning and purpose in life. Besides, the family members feel sad due to the diagnosis, experience fear because of the uncertainty of the future, lack of knowledge, and difficulty of accepting the disease. The physical presence but psychological or emotional absence leads to the feeling that the person is absent, and the relationship is lost. This may lead to anticipatory grieving, beginning with the diagnosis, through disease-related deterioration, and continue after the patient's death. Patients' narratives report on 3 stages of bodily failure that affect self-perception. According to Harris and colleagues, these 3 stages are: body failing prematurely and searching for answers, body deterioration and responses to care, and body nearing its end and needing to talk. These phases highlight the phenomenon under study, all relating to uncertainty for people living with motor neuron disease. Motor neuron disease is a complex disease, and professionals must continue to provide holistic care throughout the illness trajectory. The most difficult challenge for people with neurodegenerative diseases is maintaining a sense of self in the context of a neurological condition. Patients cannot be left alone with the feeling of losing themselves. Penner and colleagues suggest that care must attend to the deep needs of these individuals by communicating in a style that addresses both emotional and cognitive needs of patients, by thorough and holistic assessment and by appropriate referrals. Personal beliefs, unmet needs, and distress affect patients' and caregivers' illness experiences alike. Compared to those with chronic liver disease, patients with epilepsy had limited understanding of the illness and poor belief in personal control and treatment control. They had a negative emotional response to their illness and were afraid of the effects on the patient or the patient's family. Existential dangers and uncertainties worsen patients' illness experiences, even if good clinical care is available. A Scottish study by Sharp and colleagues argues that illness beliefs together with the financial situation are stronger predictors of poor outcome than the number of symptoms, disability, and distress. Lulle and colleagues measured determinants in ALS patients. The outcomes indicate that whereas the quality of life and depression were not determinants for decisions for life-prolonging treatments nor for the desire to shorten life, the feeling of being a burden was a predictor for decisions against life-supporting treatments. Patients with emotional coping strategies, avoidant personality types, and more dominant beliefs about Parkinson's disease as part of a person's identity demonstrated heightened anxiety and depression. Unmet needs are generally seen as issues of concern for which the individual perceives they require assistance. Determining someone's needs means considering his or her values and preferences, previous and current wishes, and at advanced stages of disease consultation with families and other carers. Studies on patients and caregivers with neurodegenerative disease report on various unmet needs that may lead to the loss of faith and spiritual distress. For example, in people with Parkinson's disease, the highest unmet needs were those of therapeutic, followed by social, spiritual, and emotional needs, a need for certainty, and physical needs. In South Australia, caregivers of patients with neurological conditions reported significantly more unmet needs in emotional, spiritual, and bereavement support than caregivers of people with other disorders such as cancer. As we can recall from the earlier lessons, in this context, the common caregiver challenges in this context are fatigue, planning for patients' institutional placement, and anger. If the needs are unmet, people lose faith not only in higher transcendent powers but also in the local healthcare system and especially in the neurologist's responsible diagnosis and care. This may force them to seek treatments in other countries, which again often relates to false promises and broken hopes. As an example, the Spiritism philosophy is being spread worldwide as a complementary treatment to neurological disorders, particularly epilepsy, and mental health issues, and is often executed by faith healers and traditional healers as well as shamans and representatives of different faith groups. The impact of spiritual well-being on decision-making is evident. Studies have shown that spirituality is a key component of overall well-being and it assumes multidimensional and unique functions. Spiritual well-being is a source of happiness or unhappiness and subsequent well-being for people. Individualized care that promotes engagement in decision-making and considers patients' spiritual needs is essential for promoting patient empowerment, autonomy, and dignity. Wade and colleagues from the United States demonstrate that patients with a strong existential spiritual belief system enjoyed greater happiness while confronting the lifestyle threat of neurological illness. The relationship between spiritual beliefs and happiness was related to secular, or existential spiritual beliefs, and not religious conviction. Hence, they suggest that focusing on spiritual care for older persons is significant as they are confronted by the loss of a loved one, decline in mental and physical function, and ultimately their mortality. Creating spiritual well-being must not be complicated. For example, mealtimes that make patients feel comfortable and homely are part of existential care that leads to a positive experience. Interventions to foster positive living with neurodegenerative disease in clinical practice should integrate strategies to tackle and prevent loneliness and interagency elements to increase community resources and systems of support. Support group intervention programs enhance the meaning-making of participants' subjective experiences and help to define purpose in their lives. Furthermore, caregivers cope with the unpredictability of caregiving demands through reflection on personal faith beliefs that value a focus on the present rather than an unknown future. Religious involvement, which typically contains a strong element of group support, is associated with better caregiver adaptation in female caregivers. The search for religious support is however associated with social determinants, such as education and economical status. In a study conducted in Brazil, epilepsy patients with less formal education presented a significantly higher score for the positive spiritual and religious coping index, and the unemployed people showed higher scores for the negative spiritual and religious coping index. Another Brazilian study with Alzheimer's disease caregivers reports that spirituality and faith are facilitators in the development process of the disease, associated with hope and the belief of a higher or divine existence that gives strength and feeds the desire of improvement and cure every day. A small exploratory study, about the unmet needs of families and Parkinson's patients being cared for in nursing homes from Austria, indicates that caregivers feel relieved and comforted when their care-dependent relative moves into a nursing home. The feeling of not being solely responsible for the patient's health status, hope that the patient receives good care, and sometimes can participate in activities, such as being able to play cards again, contribute to the feeling of being supported and belonging. Globally, the low number of care facilities combined with high out-of-pocket payments, long waiting lists, and limited supplies, make it difficult for caregivers to use such supportive offers. It may be a personal preference of patients to stay at home, which again points out the need to support the informal caregivers. To summarize, in the 1960s, the UK hospice movement enriched medicine with the notion of spirituality as an important aspect of the total pain concept. Nurse, social worker, and physician Dame Cicely Saunders fought for cancer patients' integrity, uniting the best care practices from nursing and medicine, and developing an Ars Moriendi model maintaining pain relief through ample dosing of morphine. Since 1991, international efforts have been made to improve spiritual care not only in palliative care but also in healthcare in general. In 1996, spiritual suffering and distress were listed at the NANDA Nursing Diagnosis Guidelines. In 2006, WHO endorsed spirituality as health-related quality of life indicator. In 2012, the International Council of Nurses stated that in providing care, the nurse promotes an environment in which the human rights, values, customs and spiritual beliefs of the individual, family, and community are respected. Despite all the efforts, healthcare professionals still report difficulty in grasping what is meant by spirituality and spiritual care, and hence, often fail to meet the spiritual needs of patients and caregivers. In a review of European literature, Gijsberts and colleagues found that spiritual care in palliative care was seen as attention for spirituality, presence, empowerment, and bringing peace. The overall problem is that spirituality is rarely promoted as an integral component of health and well-being in public health and/or patient education context, which means that patients and caregivers are equally confused when healthcare professionals, often unexpectedly, address their liberty to express spiritual topics in the secularized context of technical medicine. All healthcare workers are to provide opportunities for patients and families to express their spirituality. Spiritual care is defined as a generic health care function equivalent to emotional care or physical care and thus is not discipline-specific. That means that all healthcare professionals carry the responsibility for spiritual care provision and maintaining connectedness. Healthcare providers acknowledge the importance of spiritual care, yet, what is involved in providing the care remains unclear. Help is sought from developing assessment tools and the instrumentalization of spiritual care. Patients, however, do not emphasize a need for specific spiritual interventions. Most of them express their gratitude for feeling listened to as a whole being instead. Patients with Parkinson's disease and their caregivers need spiritual care to make sense, seek meaning, feel connected. Appropriate models of spiritual care, however, are absent. Here are some ideas: how to conduct spiritual legacy work in the clinical setting. Please note that spiritual legacy work is a complex intervention that should not be outsourced to volunteers or untrained personnel. Understanding the complexity of being diagnosed with an incurable condition, and how this affects patients' sense of self is particularly important. As people differ, they adopt varying strategies in critical situations. According to Roger and colleagues, strategies to maintain a sense of self in the context of a neurological condition may as follows: avoidance and denial, cognitive reframing, articulation of the self through imagined positive identity, strategies that reconnect to identity in the past, adjusting and altering goals, spiritual activities, humor, comparison with others, identity as shaped through social constructs, and creating communities, a reciprocal reflection of self. Regarding supporting the changes in self, narrative and qualitative approaches seem more forthcoming than using the clinical assessment instruments. Even if a large number of such instruments have been developed, these are not meant for multidisciplinary use, and are rarely tested in patients with neurological disease. Reverend Temple Jones calls for all healthcare providers to consider creatively rethinking their actions and values when interacting with patients. Biography work, where patient's biography is told, written down, edited, and exquisitely bound as a keepsake, is gaining ground in palliative care. Hear My Voice is a care program designed to provide an opportunity for persons with progressive neurologic illnesses, including brain tumors and other neurodegenerative diseases, to review and discuss their spirituality with a healthcare chaplain. The aim of this care model is to prepare a spiritual legacy document. The primary results demonstrate the feasibility of this spiritual intervention, helping patients with brain tumors and other progressive neurologic conditions preserve their unique spiritual voices. In France, palliative care patients have been offered their biography, written and exquisitely bound, as a keepsake in different establishments around the country. The patient may receive a visit, either at home or in hospital, by a trained biographer, who is an integral member of the palliative care team. The biographer interviews the patient, listens and transcribes, whilst the patient recounts stories from their life. These words are transformed into a storybook, which is offered to them, or any other chosen person, as a keepsake. The idea derives from the simple acknowledgement that we all have a story to tell. We may not all feel inclined to relay that story. However, we might feel the need to put down the luggage of a lifetime, before we die. Dignity therapy has been pioneered in Canada by Harvey Chochinov. Dignity therapy is widely accepted in palliative care. The important point in dignity therapy is to address the patient as a person, not as an illness. An Australian group of researchers have demonstrated that dignity therapy for people with motor neuron disease and their family caregivers established the importance of narrative and generativity for patients, whereas the family caregivers overwhelmingly agreed that the dignity therapy document is and will continue to be a source of comfort to them, and they would recommend dignity therapy to others in the same situation. In another cohort, the majority of participants found dignity therapy to be satisfactory, helpful to them and their families, and would recommend dignity therapy to others with similar diseases. Patients with motor neuron disease reported the strongest positive improvements in the dignity-related areas of looking after unfinished business, continuity of self-acceptance, and role preservation. There were lesser improvements in feeling like a burden, increased will to live, lessened sadness or depression, and a sense of control. In another study, people with ALS, chronic obstructive pulmonary disease, end-stage renal disease, and the frail elderly filled out the patient dignity inventory. The findings demonstrate that those whose dignity was intact reported fewer patient dignity inventory items as problematic relative to those whose dignity was fractured. Patient dignity inventory items that most significantly distinguished these groups included worrying about the future, feeling like I am no longer who I used to be, feelings of unfinished business, feeling of being a burden to others, not having control over my life, feeling that my health and care needs have reduced my privacy, and not being able to accept the way things are. Fractured dignity correlated strongly to intensity of suffering, hopelessness, desire for death, and overall decreased life satisfaction and fulfillment. Australian physician Megan Best has thoroughly analysed the literature regarding the concept of dying with dignity. She concludes that the meaning of dignity is solely dependent on the personal beliefs of an individual patient. Therefore, she promotes the idea of biography work when confronted with life-limiting illness. Healthcare workers are in the position to promote dignity in dying by encouraging patients to articulate their preferences and learning to listen to what they say. To conclude, spirituality, in itself is very subjective. What is known so far, in neurodegenerative disease, spirituality changes depending on an individual's perception of self, personal aspirations and unmet needs, and other possible life stressors, such as self-perceived loneliness or financial concerns. This points out the significance of the ongoing conversation about spirituality, which allows the patient to express his or her beliefs and values. Such conversations establish a connection between the patient, caregiver, and the healthcare provider. A conversation about spirituality is to be seen as a crucial first step in establishing a therapeutic relationship, which prepares the ground for screenings and clinical assessments that take place in parallel but cannot replace the conversation. As spirituality is not necessarily a matter of everyday conversations in a clinical setting, such initial conversations prepare patients to share aspects that otherwise might be considered as very private. Therefore, the patient's choice to disregard this aspect of care is to be respected.